we'll discuss ovarian torsion. Ovarian torsion is a gynecologic emergency caused by rotation of the ovary around supporting ligaments that contain the ovary's vascular supply. This can compromise and occlude ovarian blood flow. Prompt recognition and management of this condition is critical to prevent loss of ovarian function and potentially life-threatening complications. The ovary is primarily suspended by two ligaments, the utero-ovarian ligament and the infundibulopelvic ligament. The infundibulopelvic ligament, also known as the suspensory ligament of the ovary, carries the ovarian vessels. Because the ovary is not fixed to its surroundings, the ovary can rotate around and twist its supporting ligaments, known as ovarian torsion. Right-sided torsion is more common due to the greater length of the right utero-ovarian ligament, and because the rectosigmoid colon leaves less room for the adjacent left ovary to move. Because ovarian torsion twists the infundibulopelvic ligament, torsion occludes the affected ovary's blood supply. This can result in tissue edema, ischemia, and infarction, which can cause acute lower abdominopelvic pain. The presence of an ovarian mass is an important risk factor for ovarian torsion. Ovarian masses commonly associated with torsion include ovarian cysts, the corpus luteum during early pregnancy, and enlarged ovaries from ovulation induction treatment. Torsion is also associated with benign ovarian tumors, particularly a mature cystic teratoma. Due to the varied composition of teratomas, the mass has an uneven weight distribution, making the affected ovary prone to rotate. In contrast, malignant ovarian tumors are less likely to cause torsion as the metastasis causes increased adherence to surrounding structures. Another important risk factor for ovarian torsion is a prior history of torsion. However, ovarian torsion frequently occurs when no risk factors are present. Therefore, this disease should be considered in all women presenting with acute lower abdominopelvic pain. Ovarian torsion is commonly precipitated by physical activity. Partial torsion, arising from intermittent adnexal twisting, causes intermittent ovarian vessel occlusion. This results in episodic nausea, vomiting, and lower abdominopelvic pain, which self-resolve as the adnexa untwist and ovarian blood flow is restored. Complete torsion, where adnexal twisting does not self-resolve, causes infarction of ovarian tissue. This results in sudden onset nausea, vomiting, and severe, constant lower abdominopelvic pain. Physical examination typically reveals unilateral lower abdominal and/or pelvic tenderness. A tender adnexal mass may also be palpable. If enough tissue edema is present, the ovary may also be enlarged. If the torsed ovary becomes necrotic, fever, hemodynamic instability, and peritonitis may occur. On examination, peritoneal signs may be present, including rebound tenderness and involuntary guarding. Ovarian torsion is typically diagnosed clinically based on history and physical examination. There are no laboratory tests that are specific for ovarian torsion. However, a complete blood count is typically collected to evaluate for inflammation and to have baseline hemoglobin and hematocrit levels prior to surgery. In addition, a pregnancy test is ordered in all reproductive-aged women to rule out ectopic pregnancy and guide further management. Although not required, a pelvic ultrasound can help confirm the diagnosis. With complete ovarian torsion, pelvic ultrasound will most likely reveal an enlarged edematous ovary with absent Doppler blood flow, consistent with ovarian vessel occlusion. The edema can displace follicles peripherally, causing a hyperechoic margin to develop around the follicles, known as the follicular ring sign. However, with partial ovarian torsion, Doppler flow can be normal and does not rule out the diagnosis. Once recognized, ovarian torsion must be managed emergently to attempt to preserve the viability of the ovary. Immediate surgical intervention, typically performed laparoscopically, is indicated. This allows visual confirmation of torsion and allows the infundibulopelvic ligament to be manually detorsed, restoring blood flow to the affected ovary. Although the primary goal of surgical intervention is to avoid removing the ovary, it may be unavoidable. The affected ovary and connected fallopian tube are surgically removed, known as a salpingo-oophorectomy, if the ovary is necrotic and not viable, or there is concern for malignancy. The prognosis of ovarian torsion depends on the promptness of diagnosis and intervention. Early recognition and surgical management often result in favorable outcomes, while delayed treatment may lead to ovarian loss or other complications. To sum up, here are the key points to remember. Ovarian torsion is a gynecologic emergency. It is characterized by the rotation of the ovary around the infundibulopelvic ligament, leading to compromised blood flow and possible ischemia and infarction. Although the strongest risk factors are the presence of an ovarian mass and previous ovarian torsion, torsion often occurs without any risk factors and must be considered in all women with acute lower abdominopelvic pain. Ovarian torsion is diagnosed clinically. Similarly presenting conditions can be ruled out using laboratory testing and pelvic ultrasound. Surgical intervention is performed to detorse the ovary and restore blood flow. While the primary goal is to preserve ovarian function, salpingo-oophorectomy may or may not be performed depending on patient factors.